All right. So I don't run off. It stopped working. It's not changing.
Oh,
Yeah. Yeah, we're not advancing. Is that the problem? Yes, here we go. So I have no disclosures to make today, and there is CME available for this for those who want it. And are we sharing the screen? Is it working? Okay, for our Zoom? All right. So, thank you. So I'm Dr. Ann Conn, and today I want to pose a question. Are we at a Galileo moment in brain science? Well, in 2011, 6 of the major pharmaceutical companies paused or pulled back on their development of brain health medicines. So why? Why did that happen? Well, it was because there was a lack of biological targets, no biomarkers to monitor response to medications, and no predictive animal models. We actually don't understand how the healthy brain works, much less how an affected brain is functionally altered. We just don't know enough to make advances in Alzheimer's, Parkinson's, ALS, Huntington's, bipolar, schizophrenia, the big major brain disorders. Although there's been intense focus on the molecular level of the brain, and since 1995, Nobel Prizes have been awarded for this class of research, the GPS system of the brain, the molecular underpinnings of the circadian system. Yeah, we've been able to sequence DNA. We can predict protein folding. We can actually watch the brain at work, but yet cures and effective treatments have remained out of reach. We know so much, and yet, in a way, we know so little. We need to understand the why, the what, and the how of brain function. And all the while this is happening, the stagnation, suicide rates, hospitalizations, recovery rates have not improved. They've actually worsened. So we've been using the domino effect metaphor to conceptualize brain disorders as isolated issues resulting from chain reactions, on-off switches. Find that broken gene or protein and fix it, restore brain function. Well, it hasn't worked that well for us because even with illnesses like Huntington's, it is a domino effect. There's only one base pair substitution on chromosome 4. Slim progress has been made there. With this domino effect metaphor, perhaps we've been denying the profound complexity of the brain. Perhaps it's hindered our scientific progress. We need a better cognitive framework to develop our models, to analyze our data, generate hypotheses, and improve our patient care. So who am I? Well, I started in science as a backyard alchemist. I was the 6-year-old with the plywood table doing experiments, turning lead to gold. Later, as Dr. Beyer said, I studied chemical engineering, but I found my fit in medicine. I'm a neurologist. I did a fellowship in interventional pain and headache medicine. I treat brain disorders. I've been doing this for 25 years. Sometimes I deliver diagnosis for conditions with few effective treatments, but I stand with my patients on that balance beam of scientific uncertainty and hope. I'm also a mother. I'm the mother of my sons, Austin and Colin. And both of my sons, they developed ultradian bipolar disorder. It's a severe form of the illness when mood shifts don't happen once or twice a year, but many times a day. Austin and Colin grew up in the Louisiana swamps and bayous I'm sure you guys are all familiar with. They were little dreamers, fort builders, catching tadpoles, returning home with those mud-crusted legs and excuses. But in their late teens, they started to complain of depression. At first, it was hard to know if these were adolescent adjustment disorders or something more serious. My first husband and I had just divorced, and Hurricane Katrina hit, and it totaled my home, very difficult times. So my sons received treatment with antidepressants, and they actually weren't that effective. And it turned out this was the first stage of their illness that progressed to unusual beliefs, mood swings, paranoia, that progressive road. And for us, it led to intractable psychotic bipolar disorder. Despite my medical training, despite every advantage and access, I lost them both. They were treated at the finest psychiatric institutions in America. They went to McLean Hospital in Boston, the Harvard psychiatric affiliate. They spent months at the Menninger Clinic in inpatient medication trials. Everything was cycled through, every option, and none of it worked. So we experienced the revolving door of hospitalizations, which is sadly common with psychotic illnesses. They were treated at hospitals with unmopped floors that delivered shameful care. Psychosis is a medical emergency, a lot like a heart attack. When heart muscle and heart function are at stake and life is on the line. But psychotic crises, they actually need this kind of care. But our system is just not set up to provide that because the brain needs protection from the illness that it's enduring. The whole brain is hyperexcitable during a psychotic crisis. In our experience, we found our mental health care system to be fragmented, dysfunctional, actually a system of injustice where the legislative imperatives that mental health care and physical health care be treated equally, that just hasn't been realized. Most lawmakers and actually most people somehow still think the brain and the body are separate. And actually, I see it in my colleagues too, my physician colleagues. There's still no functional community mental health system, which we desperately needed, and that was promised in the 1963 deinstitutionalization bill. The system, or lack thereof, amplified our profound suffering. And it would be an inappropriate admission for me not to acknowledge that, but it's not the focus of this talk. 4 years after their deaths, and it's been over a decade now, I saw no new advances, no new tools, no new paradigms that would have changed their outcomes. I kept waiting for the moment when I could say, if only they had that, it would have made the difference. But it has not come. During their illnesses, I watched as the treatment for bipolar stagnated. And there is still stigma, but I want to address stigma. Stigma is better, but yet it's still present. And it really changes things for people. When folks are diagnosed with cancer, friends and family, they bring casseroles. When people get diagnosed with a major mental illness, no casseroles come. And so why is this? I think that there's a number of reasons. People don't know what to say when they hear about it. They feel frightened. Sometimes the families don't share what's going on, even with extended family and friends, and people end up cut off from the support that they could receive. So sometimes they want privacy, or is it secrecy? These are some of the issues that are dealt with. So for now, cures are out of reach, but this is what I would like you to hear. The tides of science are shifting. There is a new paradigm emerging, and I actually do feel a renewed sense of hope. And hope is actually what I'm here to share. So here are the 3 goals for the talk. First, I believe that we can actually be participants in the new trajectory for treatment and recovery from major brain disorders. So what is the Galileo moment in brain science, and how can we help? Secondly, I speak to show a way through fierce loss. I believe that we can support those suffering from major brain illnesses, families, and suicide loss survivors just by sharing our stories, because it helps decrease the stigma. And stigma actually permeates so many things, and some of us think it actually causes a decreased funding for treatment of these disorders. I'm also going to share the psychological and spiritual transformation that helped me survive the loss of my sons, Austin and Colin. And third, I will offer a pathway that relies on compassion that can help us thrive in the less extreme circumstances that all of us endure just as humans and doctors. So we're living through an inflection point in brain science, and it's time to embrace the brain's complexity. We need a new metaphor that honors the complexity of the brain. Perhaps some of you are aware of the butterfly effect. It's one of the core ideas in chaos theory. It was actually, the term was coined by a meteorologist named Edward Lorenz in the 1960s. So he conceptualized it as a butterfly flaps its wings off the coast of Africa. It changes the atmosphere. The energy propagates and transforms, and a hurricane hits halfway across the world. Well, weather, of course, is a system of complexity, but so is the brain. The butterfly effect metaphor helps explain causality that's invisible or difficult to track. And so in the brain, a tiny change in the system can lead to massive, unpredictable shifts. And it can cause a storm, but it can also cause an epiphany. So what's happening now? So the beginning of mapping the butterfly effect is brain omics. So this is a mouthful, and this is some of it. It's an interdisciplinary study of genomics, epigenomics, proteomics, transcriptomics, connectomics, metabolomics, cytokinomics, immunomics, and lipidomics. And I'm out of breath. So that's a lot. So all these layers can now be combined and correlated. We can find connections, and we can start to map that butterfly effect. So let's go in and dive into just two of them a little deeper. So genomics, how does that apply in this field? So of course we can sequence DNA, and that helps us understand, a lot about certain illnesses. But most brain disorders, they don't follow Mendelian genetics, like blue eyes versus brown eyes, right? It's much more complex than that. And that's when we need genome-wide association studies, when we look at the entire genome of large populations. So there are genome-wide association studies for hypertension, for atrial fibrillation, and there's one for psychosis. So what can we do here? We're trying to identify the disease risk, disease presentations, and biological traits. And that can actually be combined with all this other omics data that I just listed out, the different fields. So I actually donated my son's DNA to the Johns Hopkins Genome-Wide Association Study for psychosis. So this group is looking at around 200 genes that are associated with psychotic illnesses. So let's move on and talk a little about epigenomics. So in epigenomics, DNA methyl groups are added to the DNA, and it alters expression of the DNA without changing the sequence. So this happens just as we're alive, as we interact with our environment and all the things that happen to our life, the stresses, the joys, our DNA is changed. And this DNA methylation acts as an on-off switch. So I'm wondering if we have any biohackers in here. I bet we do. So there are actually commercial blood tests available where we can send our blood samples in and have an epigenomic analysis done. The three I'm most familiar with commercially are True Diagnostics, Tomps, and Revity. So what's done is you put your blood, you give your blood, you mail it off, and they give you back like organ age, brain age, liver age, of all these different things, and a bunch of omics data. So one thing we can do is we could donate our omics data that's de-identified to help advance the science. And that is one way we could all participate. So just looking at these two fields of all the ones I named, you can imagine how they could get layered together. And as we look at that data, it exponentially increases the value of it because of the cross correlation. So who's actually doing this research? That's the BD squared integrated network. They're leading the way. So BD means bipolar disorder, and psychiatry here is truly on the leading edge of medicine. So what is this group doing? Well, they're using the omics data that I've just talked about. They also use structural MRI, resting state functional MRI, and diffuser tensor imaging of the brain. Okay, and now they're also bringing in digital biomarkers, our smartwatches. So how are they doing that? When people are depressed and they're not getting out of bed, their accelerometer on their watch is picking that up. When they're manic, pacing, not sleeping, that can be seen too. So we can see what's happening with the patients when they're in the wild, away from clinic, right? And so this helps me be, less judgmental when my watch fusses at me for not standing up, right? Because these things are bringing great value. It can be correlated clinically in really important ways because it helps us see what the patient's insight is. Like if they're not getting out of bed, but they're not reporting depression, we see that there's an issue with insight. And there's new information showing that we can see when a depression is going to come before the clinical symptoms hit because of the changes in sleep. So this is really fascinating, and it's going to have very useful applications. So other clinical data that's being used are, which medications are the patients taking? Are they working or not working? And all this stuff can be correlated. So how's that happening? This is one of the positive applications of AI. AI can sift through the Sahara sand of data like no human mind could do and cross-correlate all this diverse and vast information. It can build models with vibe coding. It can help us design new drugs. And I mean, I'm using AI as my personal assistant to practice medicine. Sometimes in a case, I'll use open evidence and I'll search open evidence. I get CME for it, and it helps me formulate the care plan and analyze the data. It also helps me write denial letters. Those denial letters, y'all don't know about those yet. They're miserable. So I love it when AI is writing it for me. So I think you can see this breadth and depth of what's happening. And I think it helps us see that we are going to go from react and rescue to predict and prevent. And I mean, we're going to have the kind of truly personalized medicine we all dream of. And then the other really important thing that's happening with this group is they're already cross-pollinating with the Alzheimer's researchers, Parkinson's, Huntington's, ALS, because, this is a tide that's going to lift all ships. They're all cross-talking already. And so it's so promising and exciting. So now I'd like to talk a little bit about psychosis from my perspective as a neurologist and a mother who accompanied my children down the road of psychosis, intractable to treatment. Their suffering was unbearable and intense for them and for me to witness. First, I want to point out that most people with bipolar disorder do not get psychotic, but they did. So what is psychosis? Well, we're going to talk about it with respect to the predictive brain. So the brain is not a passive receiver. It's actually an active predictor whose primary job is, of course, to keep us alive. So maybe you'll say, what do you mean by predictive brain? Well, let's look at this video if I can get it to play. And we're going to learn about sine wave speech. Okay, so the brain was primed, and our brain heard what it expected to hear, right? Because the first two times we heard like squiggly business, not sure what it was. Then we heard the words buried in the squiggles. And then when we heard the squiggles, the words were evident. And once this experience has happened, it can't be undone. So then when you hear the squiggles, you hear the words that we weren't hearing the first time. So this is an example of how the brain is in a predictive mode. So here in this next section, I'm relying on the work of Anil Seth and Carl Fresden. Oops, let me see. Okay, so Anil Seth, he had a TEDx talk in which he proposed our reality is actually a controlled hallucination. This TED talk has been viewed 15 million times. It's wonderful. I recommend y'all look at it. And so these are some of the ideas. So the brain is constructing, okay? It's actively constructing our perception. It's predicting and interpreting sensory input. It's not just passively receiving, what happens in the world. Each person Each person's brain is unique. It has unique filters, organizes information differently, and has probably a different conscious experience and a different reality. So conscious reality may be a controlled hallucination. And the key part I want to circle back to is it interprets sensory input. This is very important because that's what keeps the hallucination controlled. Okay, when the feedback loop that checks the sensory input goes offline, the hallucination is no longer controlled. Okay, so altered predictive control, right? So we're going to talk about, psychiatric illnesses with this model in this context. Okay, so what's depression about when you use this model to apply it? Well, it's rigid, negative predictions and perceptions about the self that have been shaped by experience and biology. In this context, we can understand anxiety as hyper precision on threat prediction, and psychosis, overly confident priors that override that sensory input. The brain's best guess is too rigid or too noisy. So let's understand that better with an example. Okay, so perhaps some of y'all have seen somebody in a psychotic episode, and we hear complaints like the TV is talking to me, my cell phone is talking to me, my computer is talking to me. So let's think about what that means in this context. So if a person is watching TV and they're having internal thoughts about the TV program, they have memories, it's triggering memories of things that have happened that come up in the show, or having seen the show again, their internal reaction to the show. These internal reactions are not suppressed. Instead, they're interpreted as coming from outside, causing the person to hear their own thoughts as voices coming from the television. So they draw the conclusion, the TV is talking to me. Okay, because the sensory feedback loop that about sound is not adaptive in this context. So it is adaptation gone awry. That's one definition of psychosis. It is not a personal failure. The people usually feel, in my experience with my children, it feels like a personal failure. My son said that when they had psychosis, but it's not. The predictive control of the brain is not functioning in a way that supports the individual to function in society, right? Which is deeply painful. So the summary statement is, we don't perceive the world or our body as they are, but how we expect to see it. We perceive the brain's best guess shaped by prior experience, biology, and the need to stay alive. So I'm going to share a little bit more about our personal story. So some people ask, how do you go on after a loss like that, the loss of your two children? And others, they're afraid to ask. Part of the answer, I think it's fundamentally a mystery, but then other parts, it's knowable. So I've had a meditation practice since the 1990s, and I believe my meditation practice helped stabilize my mind as we endured life and death circumstances many times. And I'm not going to go into the details of that part, the techniques I use, but I can tell the value in my life cannot be overstated. Another critical factor to help me tolerate this kind of loss was I was able to shift my lens about our experience from one of empathy to compassion. And so these are the definitions we're going to work with. And I'm going to use these definitions because they have neural correlates. So empathy is to feel with a person, right? It creates emotional resonance. And compassion is the impulse to act for the benefit of another person. So in empathy, we see into people. In essence, we're creating a virtual reality image of what's happening with another person. And that's when we're in conversation with them, that's how we understand what's going on with them. And this also happens when we watch sports. For example, when we watch somebody perform a sporting event, the same areas of our brain are active as the person performing the event. And one of these circuits are the mirror neuron circuits that facilitate this. Maybe this is why we all love the Olympics, right? Because we get to participate and take part in things that most of us are not capable of, right? And we love it. I love it. Most of us do. Yeah. So this also explains why when we're with some people, we have joy and laughter, and we're with other people, we're emotionally drained, right? Because our minds are literally coming into equilibrium with people. And that's important. And we need to be careful with that and make very mindful decisions about how to approach things. And I'm going to get into that more. So for me, with my son, when my son Colin first began complaining of depression and nightmares and trouble in his relationships, I felt concerned. And as his illness escalated, I felt alarmed and even frightened. And when he got psychotic and he began describing these blood-soaked visions, I just felt devastated that my child was suffering in this way. It just felt intolerable to me. And I stayed with him and I stayed by his side. And after several months of this, I began to feel like it was actually a danger to my own psyche. I could see into him too much. And I felt I was at this precipice in my psyche that I had to pull back or something bad was going to happen to me. And I wondered, how much should a mother listen to the psychotic narratives of their child? How much should I try to see into him, and how much should I let myself? Perhaps I had read about this research about empathy and compassion. I really don't know. But somehow I was able to gain clarity that I needed to switch my lens and look at this with eyes of compassion. And I do think my meditation practice helped calm my mind enough that insight could come forward. So when we're trying to support someone in a crisis, a life and death crisis, we need to think carefully about what that support looks like and what is actually helpful and skillful in this situation. So I recognized that I had obligations to myself, my husband, and my other son, Austin, who was not well, but he wasn't yet psychotic. And I was able to reel my mind in and stop visualizing the psychotic material that he was telling me about. And this was not abandonment. It was a shift in my relationship to his pain. And after I had this insight, my body like ratcheted down, and my mind, I felt a lot calmer. I was much calmer. I was able to make more skillful decisions and be more clear in the way I did things and actually be more helpful in an appropriate way. So I do think my meditation practice anchored and steadied my mind and helped facilitate this switch. So then when my other son, Austin, became psychotic, of course, it was an utter nightmare, truly. But I had more skills. I had more tools. And I did not have this empathetic crisis. It was a terrible crisis, but I wasn't in that kind of danger because of being over-identified with him. And I'm going to talk about that. So what does this mean for you all? My story about empathy and compassion, and how can it be applied in your life? So many of us here have experienced burnout. Some of you guys are too young. Maybe you haven't had it yet, but most of us will deal with burnout, and we're vulnerable to it. And we are vulnerable to it because we are so close to people that are really suffering. And when we practice medicine for a long time, it's a lot of load of exposure to that. We also work under a dysfunctional payment system. We don't have appropriate institutional support. The society of, the roles of physicians in society are changing for better and worse. And we experience moral injury, both directly and as observers. So there's a lot of reasons that we're vulnerable to burnout. And I think it's important to learn that early and learn tools to fortify oneself. And even later, we can recover. These tools can help us recover. So I want to explore this question of empathy and compassion using just a fascinating scientific study. Okay, so you can't see the top, but oh well. Okay, so there were some fMRI studies done on empathy and compassion. Dr. Tanya Singer, she's a social neuroscience from Germany, conducted, the study, and the subject was Matthew Ricard. He's a Buddhist monk, but he also holds a PhD in molecular genetics from the Pasteur Institute, an Olympic level meditation practice. I mean, they compile the hours. It's just this amazing number of hours because he'd been practicing meditation for at this point, it was maybe 50 years. Okay, so how did this go? The night before they were going to do the studies, he was at home in his hotel room and he watched a documentary on Romanian orphans. These Romanian orphans, some of you all might remember the story, severe neglect, with no social touch and, not care, loving care. And the children had severe mental, physical, and developmental delays. So when he arrived at the lab that morning, he went into the scanner and he invoked, in his training with an empathetic brain state. And he thought about the suffering of the orphans. And he stayed in the scanner for 45 minutes. They collected all the data. So he gets out of the scanner and he says he's emotionally drained and exhausted. He just felt terrible. And Dr. Singer said, do you want to just come back and do the compassion part tomorrow? He said, absolutely not. I want to do the compassion meditation now. So he got back in the scanner, and this time he invoked compassion toward the orphans, and that he had seen on television the night before. And when he got out of the scanner, he reported feeling calm and rejuvenated. So what was happening in Ricard's brain? And what does this mean for us? Well, when the fMRI data was analyzed, it was really fascinating. So what was found is that empathy, it activates the anterior cingulate cortex and the mid-cingulate cortex. These are the same areas associated with physical pain. That's fascinating. Okay, so it creates emotional entrainment. That's a word Ian McGilchrist coined. So what it does is it connects us with the other person in a very deep way, and it can be really valuable because that's what helps us take care of an infant and meet the baby's needs. On the other hand, emotional entrainment, it can grant us that internal permission to rush the football field after an LSU win, right? Because we're with the crowd. All right, but it can facilitate a riot. These are all examples. This is our human biology, right? It can do all those things. Okay, but we can get trapped in this empathetic mode and we can fall into empathetic distress, over-identification, empathetic over-arousal. This is the effect of the suffering of another human being that it has on us, and it can cause this burnout. So we can see this in caregivers when we see this collapse of the caregiver or when they, run away and abandon things. And I've actually done both these things. I've been on both ends of the empathetic pathology equation, and I'm going to talk about it. So in my first year of neurology training down the street at Big Charity, like Dr. Byer said, I would be on call. I saw patients come in. They had developed AFib, nobody knew. They got a small clot in their heart, threw that to their brain, had a small stroke. So back in that day, they were admitted to the hospital. I would start the patient on Coumadin, go through everything and explain to them, you need to take this medication because it'll help you keep from having another stroke. Then several times I would be on neurology call again, and the same patient would come in, this time with a massive stroke or a fatal stroke. And for me, it was just devastating. I was so upset. I'm like, I don't know if I can continue to do this. That's how I was reacting to it. It was very painful. And one of the unhealthy tropes that I hope is not there anymore when I trained was people would say, the patient died on me. Well, patients don't die on us, and neither does family. They die because the causes and conditions have come together to create a situation where their life can no longer be sustained, right? It's not so personal. Somehow I began to understand that my job was to explain to the patient and to offer treatment, and their job was to decide whether to participate in that treatment. And I also began to honor and understand that I don't know everything going on in people's lives. I don't understand all the factors that, how they make their decisions. And my interaction with them may just be like a small blip. I can't know everything. None of us can about what they're experiencing and thinking. This helped me clarify my role, and I was able to continue training. And I let go of some of that inappropriate sense of over responsibility. Then on the other side of the empathy equation, I trained at Charity. I cut my teeth as a doctor during the HIV crisis when it was not a long-term illness like it is now, treatable. And I cared for patients on the infectious disease ward. We called it West 9 at Charity. And the physical and mental suffering these people endured, it was tremendous. And many of them were my age. And that's what I think broke through my denial, because I'm like, really bad things can happen to young people. I mean, I was young and healthy, and I was deeply affected by what I saw. Sometimes I had to go to the bathroom and regroup and take deep breaths. And sometimes I actually avoided certain patients' rooms. And I now understand that sometimes this was actually abandonment because I was in empathetic overwhelm, because I didn't know how to downregulate what was happening to me. So we do want to be in resonance with people that are suffering. We need to start with empathy, but convert to compassion quickly. We need to have clarity that even though our body can be responding in a resonant way, we are not that person. And we need to get that clarity and downregulate. This was particularly challenging for me when my sons were sick, because when the person suffering is one's child, my child, or a family member, it's challenging to downregulate and get that clarity and turn the autonomic nervous system down. So let's talk about compassion. Compassion is the impulse to act for the benefit of another person. It activates completely different areas of the brain: the medial orbitofrontal cortex, the ventral striatum, and the premotor cortex. Now, this is fascinating. So when if I'm going to pick up this cup and have some water, I thought of doing that, right? Until my premotor cortex was active before the motor cortex was active for me to get the water, right? And so the brain is actually moving to help, which to me is just amazing. So there's a motivational drive to alleviate suffering. Compassion has positive feelings. It's an other-related emotion. One forgets their sense of self. It promotes resilience, pro-social behavior, and there's cognitive and moral alignment. We're doing and thinking things that are in alignment instead of, being in the, dysfunctional part of the empathy equation, right? The person, we're not objectifying the patient. They're not being ignored or abandoned, or our family or our friends, our loved ones, whoever it is we're in relationship with, because these things apply outside of medicine. So compassion, it's the antidote to empathetic distress. And I think that's really important. So I'm offering this, a pathway to explore the conversion from empathy to compassion. So we can apply this in the difficult circumstances, we see at work in our personal life, because we'll all have difficult circumstances, both at work with ourselves, our loved ones. And I think we all know that the alarm system in the body, it just can't go off all the time. That's unsustainable. The autonomic nervous system, that fight, flight, freeze, fawn, it needs to be turned down. So once we know the state of the other and we have empathy, we need to switch to compassion. So I want to talk a little bit, give a different kind of an example that is usually pretty familiar to a lot of people. In the 12-step community, there's a slogan. It's called Detach with Love. So detach doesn't mean kick people to the curb. Okay, it means to switch from empathy to compassion. And this points to the profound responsibility we have to manage our emotional state for the benefit of ourselves and for others. So the Dalai Lama says compassion is the radical act of our times, and I agree with him. Okay, so a common time that there's a crisis of empathy in a family is during a substance abuse crisis. Addiction is common, and we'll all see it at home and at work for the rest of our lives. So when an addiction starts to escalate in the family, sometimes people will start counting the drinks of the person. They'll drive around to the bars. They'll track them on GPS. They'll try to clean up their messes. And most people hold a belief that they can stop the other person from drinking. They can show them, they can teach them, they can convince the person. But holding this kind of delusion, it's very common that we can make the other person stop it. For me, in relationship to my sons, it was particularly strong for me that I thought I could rescue them and save their lives because, of course, I've saved lives in my role as a doctor. And so it's very important to understand where our acts can be skillful and where our acts will be unskillful, and understand the limits of our power and what we can actually affect. What is our appropriate sphere of influence? So it's not true. We can't make people do anything once they're about 2 years old. And sometimes not even when they're, before 2 in certain kids. So in families, whenever I've seen this before, and I'm thinking of a particular situation. So I want to talk about this because it puts a point on human biology. So perhaps y'all are familiar with broken heart syndrome or Kawasaki syndrome. So I think it helps us see that there is no separation between the brain and body, that it is all the same thing. Because when people have an emotional shock or loss, they can go into congestive heart failure. And a friend of mine, when her daughter had a relapse in her addiction, she actually experienced congestive heart failure. So I think this just puts a point on what's happening and how we need to care for ourselves and understand how to act in the world. So compassion is renewable, and it's actually contagious, in my opinion. So here's how can we participate? Here's the call to action. So in the big old list of omics stuff I gave, there's histology. Histology's in that list because human brain tissue is urgently needed. The Harvard Brain Tissue Resource Center only has about 8,000 brains. Brain donation is a different pathway than organ donation. So I pledged to donate my brain to the Harvard Brain Tissue Resource Center. They study psychotic brain disorders there. They need brains from both affected and unaffected people. They also study the other major brain disorders, Alzheimer's, Parkinson's, Huntington's. They do some CTE, but that's mainly elsewhere. So I encourage you all to consider donating your brain. The need is profound, and to bring it up to families and family members, because we can participate in this Galileo moment by offering our brain tissue, by offering our omics data, by anonymously sharing our smartwatch data, our digital fingerprints. I also ask that you don't rely on the domino effect. It works in other areas, like areas of metabolism. There have been CRISPR gene, you can fix that. It just doesn't work for brain health. We need to think of the butterfly effect. Things are changing very rapidly now, and most of you guys are early in your career. And I think it's more important than ever to commit to rigorous learning, because the transformations are going to be coming fast now, and it's very exciting. And I encourage you to act with compassion for your patients, yourselves, your colleagues, your loved ones, your friends. That's the personal Galileo moment. That switch can change your life, help you last as a human, help you thrive with whatever may come at you. So things are starting to come clear. None of this was visible. And now the sky's opening. We're just seeing this emerge. It's clear what's the dream is coming true, personalized medicine. We're going to be able to change the trajectory of major brain illnesses that have been untouchable up to this point. So I want to conclude by just saying that my talk is to honor my sons. And I want to share that my book about our experience through my eyes as a mother and a neurologist is going to be published by Simon & Schuster next year about this time, April 6, 2027. And I'd ask all of you to please consider joining me in my wish. And my wish is that all minds may be at ease and free. So thank you. Thank you for listening.
We do have a few minutes. I don't know, Dr.
Yeah, I'll take questions.
Questions.
Yeah.
You've covered a wide variety, and as we had discussed, Dr. Conn kind of included interweaving a lot of brain science, personal health, wisdom from clinical practice, but also research, which again, I'm just, reminding us of our poster session next door and the diversity of questions that our residents and faculty have asked to kind of help us become, rise to that challenge that you had. I keep asking questions, be better practitioners, better healers in our sphere, in our scope of impact. But any questions for Dr. Conn?
This is a medical question related to your son. I'm sorry for your loss.
Thank you.
I don't know the timeline of when they died, but I remember in medical school or residency, that like anti-NMDA was coming out, or like people were starting to test for it, and talked about how it's intractable. Was that around that time, or were they ever? And they, were they ever tested for that?
It's a great question, and they were, because I'm a neurologist. Okay, so if they were treated in the best places in America, like I said, they went to McLean and Menninger's Clinic for a long time. And so routinely, they didn't do things like get EEGs and other things. And I did ask for that. And so it was terrible, intractable, rapid cycling bipolar illness. Yeah. Yes.
Really often talk. I think you have a super powerful story. I had a question about the DD2 thing with genomics. How are they collecting that? Is that like sign up online, or like a single institution, multi-institution? How's that?
Thank you. Thank you for asking this question, because I wanted to say more, but about them. So I do have a podcast where I interview the executive committee. It's called the Conn Job, but you can look it up. And so in essence, they have study sites in Canada and America, at, major academic institutions. It's at like USC. There's actually one in Houston, along the East Coast. They're in Chicago, and there's a site in Canada. So they enroll patients. Patients have bipolar 1. These patients all have bipolar 1. And I mean, it's just amazing what they're doing. So they collect blood. They collect blood periodically and constantly, up and down with the patient's symptoms. And that's why I was calling it a digital biomarker. Well, no, that's that's from the smart devices, but it's a huge data set. So they're collecting it constantly, and they're in very close care with psychiatry. They're psychiatrists with all the medicine trials, and they're, doing their smart watches, all the subjective and objective, the brain imaging. I mean, the way they're analyzing this data is just amazing to me. And that they're already talking to the other groups. So like, I really do, they say it's going to lift all ships, that all the major brain disorders will move by this. And I mean, psychiatry really is leading the way, because we're going to see these omics studies. They think they're going to propagate and spread to all the other fields of medicine. And it makes sense to me that it would. I mean, it needs to go into, almost every field of medicine could benefit from this kind of analysis. I do want to add this. I think this is important. Okay, so this study is philanthropic, and 3 families gave $50 million apiece. And this is all public. The families, it was Serge Brin that founded Google. They had bipolar disorder in their family. Ken Dalton, he headed Keystone Capital. They have 2 sons with bipolar disorder. And then I'll try his name, David Bazutsky. Is it Roblox? You got the video game playing platform. Maybe I'm saying it wrong. Y'all can help me. Anyway, they gave $50 million also because they have a son with bipolar illness. So this is very generous, of course, but it also means their funding is secure. Because, for example, when I went to the Harvard Brain Tissue Resource Center and their funding is not secure. It's really terrifying, actually. And so this group, the BD Squared Integrated Network, they have funding. And so their studies will be able to continue. And, we want everybody else for their funding to be restored. And we're hopeful for that to happen because brain science has been hit hard in the funding cuts. Thank you. Yes, ma'am.
You identified empathy as maybe an overused muscle, if you will, and so compassion is the antidote to that.
Mm-hmm.
Are there any resources or thoughts you have on developing that compassion muscle?
Yeah, that's a great question. And I don't have resources. This study that I referenced you can look it up. It's a well-known study. It's like a landmark study on this whole group of studies been done on these Olympic level meditators. A lot of the studies were done at University of Wisconsin-Madison by this guy, Richie Davidson. I've been following him for 30 years. So I don't know about training. I will say this, there are compassion training programs. A big one is at Stanford, and actually Emory has one. So they try to train people in the skill. I haven't taken those courses. Some of my colleagues have, and they found them incredibly beneficial. So I guess I kind of backed into the answer. Yeah. Yeah. Anybody else? Yes, ma'am.
Especially within our
Yeah.
this one increase omics to be able to testing, do they advertise what they're doing like publicly, or is there incentives to participate, and like how are they able to
Yeah, these are great questions. I actually don't know how they're recruiting patients fully because a person very close to me that lives near Los Angeles, I tried to get him into the USC study. He has bipolar 1 with psychosis, and they were closed. So I can't fully answer your question about how they enroll. The medical mistrust, of course, is real. People don't want to give we all should be donating de-identified digital data. That's a way we can participate. But even I feel nervous, right? I understand what you're saying about the mistrust. That's such a huge societal problem. I wish I knew better how to answer it, but I honor it as being utterly real. Yeah. Yeah. Anything else? Yeah. I'm going to be judging. I welcome y'all to just come talk. Anybody that wants to visit with me that doesn't want to speak out loud, so please do so.